Welcome to Market Shapers, a podcast about harnessing capitalism for good. I'm Inder Singh. Over the years, I've had the privilege of working with incredible people, building products, forging deals, and shaping markets that have impacted millions of lives. On this show, I sit down with the leaders, innovators, and behind-the-scenes deal makers who've changed the way markets work, often in ways most people never see. We'll unpack how they did it, what they learned, and how those lessons can help tackle the big challenges ahead. My guest today is David Ripin, Chief Scientific Officer at the Clinton Health Access Initiative, or CHI. I had the pleasure of working closely with David during his early years at CHI. Today, we're diving into a watershed market-shaping effort, the price reduction of a key drug, Tenofovir. This price reduction helped shift and scale treatment for millions of people living with HIV/AIDS. When Tenofovir first arrived, it was more expensive than the entire 3-drug cocktail used at the time. And global leaders argued it should not be deployed in developing countries because budgets could not stretch far enough. What happened next changed that. CHI and its partners brokered a series of deals that dropped the price of Tenofovir by nearly 60% in under 4 years. And that helped unlock widespread adoption. Let's get into it. Dave, it's great to see you. Welcome to the podcast.
Fantastic. I'm happy to be here, Inder.
Dave, let's talk about Tenofovir. Tenofovir today, and you should elaborate on this, is a product used by 30 million people globally. It's life-saving. Let's go back to when it first came into the market. This is 2006, 2007. What was the problem with Tenofovir's introduction in the market?
You know, there's a lot that's been made about the miracle of antiretroviral treatment. And the first drugs, AZT or zidovudine, but even before that, a drug called D4T or stavudine, had really a lot of nasty side effects. Somebody living with HIV, though, in the absence of any other alternatives, you're going to take those drugs. Now, the challenge was these side effects were really quite horrific: peripheral neuropathy or nerve pain, even some fat redistribution, which visibly altered the way folks looked. And some of these drugs were just so difficult to take every day, several times a day, that patients at a certain point were ready to give them up. Tenofovir came along. It's dosed once a day instead of multiple times a day. Much lower and better side effect profile. Just a better drug all around to those older drugs. And the standard for treating HIV is to use 3 drugs at the same time. So Tenofovir would replace one other drug in this 3-drug cocktail. The commercial developers of Tenofovir, a company called Gilead, had a visionary access program where they granted voluntarily license to several generic companies overseas, primarily in India, in order to enable these companies to make and sell Tenofovir in low middle-income countries. And at the time, that technology was getting Tenofovir into the market at around $200 per full year of treatment. Now, that doesn't sound too bad, but we had a few million patients on treatment at the time. And while Tenofovir cost $207 as a single agent, the AZT-containing 3-drug cocktail was available at around $160. You multiply that by the number of patients on treatment, and there came to be a choice: treat fewer patients with a Tenofovir cocktail, or treat more patients with the more toxic older cocktail. So we, in partnership with the Gates Foundation and an academic from Johns Hopkins University named Charlie Flexner, actually got a multidisciplinary group together. And we said, what are the most impactful projects we can work on to make ARV treatment better for patients and make it more affordable? Out of that meeting, one of the priorities was Tenofovir. And so we set out to make Tenofovir more affordable and to support generic companies to combine it into a once-a-day treatment for HIV. That really the first time a once-a-day treatment would be available for millions of patients in low middle-income countries.
Dave, that's a great setup. And you're talking about a market here where a new product, this is not uncommon, a new product comes to market, it's available, but it's way more expensive. In a resource-limited setting, in a setting where you're talking about millions of people's being on treatment due to donor dollars, you can't increase that cost. So what do?
Yeah, well, there was a lot of work to do on reducing just the underlying cost of making the drug. And as part of that, manufacturers get more efficient the larger the batches that they're making of drugs are and the more experience they have. At the time, we recognized that there was going to have to be a period where we found donors willing to pay a slight premium for a newer, better treatment as we work the market up to that volume, that scale that would allow the cost to come down to equal or lower than the current regimen. So there was a lot of visionary investment by key donors. And this really is where I would highlight this organization, this donor called Unitaid. Unitaid were incubated under the WHO, created out of a vision by the French government that if they were to place a very small tax on airfares for anyone flying through France, and you took those fees, you could create a donor that had a lot of leverage in the low middle income country market. And Unitaid chose to focus on specific HIV treatments that were not the focus of other mainstream donors. They focused in two key areas on access to pediatric HIV treatment. And they also focused on second line treatment. Second line treatment is the 3 or 4 drug cocktail you take if that first cocktail I described stops working. And this is important because tenofovir became an important component of second line treatment first. And in part, it was because it was more expensive. So Unitaid, as a donor, were one of the first organizations buying tenofovir in bulk. And it was really their visionary willingness to enter the market with the intent of making these products more affordable that also helped us get there.
So let's talk about those techniques. When you first introduced tenofovir, you introduced it at a higher price than was currently available for first-line treatment. When did that switch? And what were the tactics or the techniques that enabled you to get it lower? And was this just sheerly volumes?
It definitely wasn't sheerly volumes in there. I mean, there was a lot of work we had to do. Let's take a step back. Like, how do we make these drugs in the first place? These drugs are organic compounds. You generally run a series of reactions using specialized starting materials. Imagine big vats, like if you've ever seen a beer brewery. And once you run your reaction, then you have to get the stuff out that you want. You're not going to get everything you want. You have to clean up what you get. And after a series of these reactions, you're going to get an overall yield on the product, and your product cost is going to depend on how much work is it to run all those reactions, what's the yield I'm getting out, and all of that depends on how much I have to pay for those starting materials upstream. So with tenofovir, we recognized that we needed to look at a few factors. Number one, there were 4 key starting materials for tenofovir that we wanted to work on. We'd done an analysis of the reaction process, the chemical process for manufacturing it. We had identified these 4 as significant drivers of the overall cost of the product. We also saw that there were opportunities either to substitute less expensive starting materials or to improve the yields of the process itself. When I was in the pharma industry, I was a process chemist. Like, our job was to understand how you produce drugs. How do you do it efficiently? We really started there, looking at what does the process look like right now? What does that lead to in terms of cost? And obviously, there's some markups there for profit companies to operate, and then that becomes your price. And then we asked, okay, how much of this cost can we knock off by either improving or reducing the cost of the raw materials or improving our overall yield? We also figured out how to spend less time in those vats. So you make the vats more productive by running a shorter process.
So let's just say that you have come up with a new, more efficient way to make a drug. Theoretically, if that manufacturer incorporates that new, more efficient way, they can win the volumes for a particular buyer because they're offering a slightly lower price. Now, their volumes are going up, prices are coming down, they're making a healthy margin. Why aren't they adopting? And or why aren't they adopting fast enough?
So I described how do you make the drug intrinsically? What does it cost? It's not that easy. In order to ensure the quality of drugs that people are taking, as we all know, there are regulators out there. In the US, it's the US Food and Drug Administration, FDA. The WHO has an entity which they call the WHO pre-qualification or WHOPQ. Every country out there has their own regulator. Regulators are looking at a variety of issues. Does the drug work? Have I looked at the data which proves there are studies which rigorously demonstrate the drug works? And then if I'm convinced the drug works, is the manufacturer making this drug in a way that always makes the same drug at the same time, most importantly, with as few impurities, other stuff I don't want in there? Do I have ways to measure and understand if there are impurities in there? And the regulators care about a lot of stuff, from who are you buying each raw material from? Are there impurities in each raw material? Because those can carry all the way through to the finished drug. They care about any little change you make to the process itself of making the drug. And anytime as a supplier, after you've gotten your drug approved, you want to make changes, you have to go and ask the regulators for permission, go through a process to ensure that the changes you've made are not going to adversely affect the quality of the drug that patients are ultimately taking. So all of this involves cost. We're trying to deliver HIV treatments for patients across low middle income countries. Some of these generic companies are making products which are registered in as many as 90 plus countries. Each one has their own regulator. It takes time, money, technical writers, regulatory fees every time you want to make a change with every regulator of every country you're selling a product into. So this is a big deal, I guess, is the point. And if I'm a supplier and I've got an approved drug and an approved process, and I make a few tweaks and I can do 5% better, I have to ask myself, is the amount I'm going to save with that 5% going to justify the level of investment to go through this regulatory process and make the change? Generic companies model, which is different than pharma companies, originator pharma companies, is to add more and more products into their portfolio. So I have a choice. I have a drug, it's approved. I can either have my researchers spend time lowering the cost of that drug, or I can have them develop a second drug and have two products to sell in the market. So I'm really only going to deploy them to optimize that drug I already have approved. If there's a massive gain to be had, if my competition is threatening to outcompete me, and in order to stay in the market on that product, I have to make improvements and the like. So while all of this sounds fairly basic and intuitive, there's a lot of work back there. And because all of these companies are focused on introducing the next drug in, at some point you get into a market situation where you have a local equilibria.
Dave, you're saying that because of the kind of incentives and patterns that exist here, where a company is used to launching the next product over optimizing the current one, they get into some sort of status quo situation, which you're calling a local equilibrium. Is that right?
Yeah, that's right. And that's like the mountaintop lake, right? The water could be downhill, it would be happier downhill, but the water doesn't know that, right? The water is in this mountain peak. and is perfectly content there. And it takes someone coming along and drilling a hole to disrupt that market and then reset it so that everyone realizes, oh, okay, the water needs to be down there now, or let's call it what it is, the price. And so that's really what we had to undertake when we were focused on lowering the costs of tenofovir.
This is a really great example. I mean, you're talking about understanding the incentives and constraints of actors in the market, in this case, suppliers. There's some clear opportunities, there's some clear constraints that they have, and they've got to use limited resources and figure out where to allocate them, right? So you're talking about understanding incentives. Ultimately, you came in and were able to encourage the suppliers to implement new, more efficient processes for production, but it took a while. What was the straw that broke the camel's back? Like, how did you actually do it?
Yeah, generally, like, let's say you have a market and you have two or three companies, they've developed the drug, they've spent a lot of money doing it. They're generally competing, they're using basically the same technology as each other, so their costs are comparable. They're going to come to a relatively stable pricing level. Now, the other thing to remember is this is absolutely massive generic drug market. 25 million to 30 million people are taking the same drug once a day, every day for their entire lives, and represents a massive business opportunity. So if I'm supplier number 4, I'm the next supplier and I'm looking at this market, it looks really attractive to me. I want in. But I see already, 3 guys have market share. It's hard to come in. So if I can incorporate changes that get me a cheaper starting material or a more efficient process before I spend money the first time to develop this drug, I'm going to come into the market with a market advantage. I'm going to disrupt that equilibrium. I'm going to push the water down the hill. And so we've worked with a lot of companies who are in the market, understand why there's a need to make the change and invest. But there's also an opportunity when you find an up and coming company who wants to break into the marketplace and really, want to do so using some kind of technical advantage to their competition.
This is one of the lessons that I think can be taught here, which is the 800-pound gorilla has little incentive to do anything because they already are the 800-pound gorilla in the market. They are the winner. They're the leader. They have little incentive to do it. The second supplier in the market, maybe they have some level of incentive, but they probably also have a really stable, big business. It's usually the third supplier who's hungry enough to be willing to take risks or do new things. And when you get the chance to work with them, if you can find a new entrant or a third supplier to work with, well, then the second and the first have no choice but to start paying attention because their market is about to be disrupted. And so if you're doing market shaping work on the supply side and you're trying to take an existing marketplace and change the dynamics, you're trying to drop the price of the drug or you're trying to improve the quality of the drug, you're better off in most cases working with the hungrier supplier because then the entire chain has to pay attention. I think this is a really important tactical point in market shaping on the supply side. Would you add anything to that?
No, I mean, I agree, Ender. We as Chai actually opened a small lab in the Philadelphia area. We employed some really smart chemists. We did our own work in the lab. We came up with something we thought was more efficient and better. Now, are any suppliers using the process we developed? I can't tell you that. But what I can tell you is we contributed to destabilizing that equilibrium by demonstrating, by proving, by publishing that something better is possible. Once that moment of disruption happened and a new supplier was coming into the market with a process delivering the same pricing, the same cost we had modeled, now everything's disrupted. These generic companies, I mean, this is what they do for a living. They have really great and smart process chemists. My bet is they've bested our technologies a few times over since then. The point was to figure out, how do I take the market at point A and get it moving to point B?
Can you give an example, perhaps related to tenofovir, of what Chai did to further reduce the cost of production and therefore the price related to raw material side of things?
Yeah. So the materials you put into a process can do a few things, right? Like you can have a solvent, think of water, think of the acetone, which is in nail polish, something that keeps all the chemicals in there moving around, bouncing into each other, reacting. Some raw materials become a part of the drug itself, right? But then I have other raw materials which are affecting or causing the reaction to happen. And so in the tenofovir process, there is a particularly expensive reagent. It wasn't actually even becoming incorporated into the drug itself. And this reagent was adding a considerable percentage of cost, over 10% of the cost of the entire process. And so we did some research and we actually found a different base that was way cheaper, easier to handle.
So when you're thinking about a technical analysis, you're doing a cost buildup. You're trying to understand what the cost of production of a particular product is. Ultimately,
Yeah,
there's lots of stuff you can do in the market to make the market more efficient, to reduce costs of packaging, to reduce costs of distribution. But at the end of the day, the cost of production is kind of like that's the lowest you're going to get, even if you make everything else efficient.
that's right.
So we're going to take a big step back. There's this wonderful new drug. It's better, it's safer, called tenofovir, about to be introduced in the market. But it's more expensive than the entire 3-drug combination.
Right.
Step one was introducing it to the market to get some sort of minimum volumes. And in the case of tenofovir, that became second-line treatment. People who first-line treatment wasn't working for, we're going to give it to them because a different drug, it'll work for them. So get some volumes. At the same time, when we introduce it, we want to make sure it's priced as effectively as possible. So there's a couple levers that Unitaid, Chai, and others tried to implement. One of those levers is packaging harmonization across countries. Because every time you have a slightly different label, where you have one particular labeled product for Uganda and another one for Nigeria, and that's a lot of warehousing costs. If you get it wrong, you might have to waste some of that product.
Those are different products, right? Product A doesn't compete with product B. I have 2 lower volume products now as opposed to 1 higher volume product.
So there's some level of Unitaid and Chai working together to harmonize packaging to reduce the costs of entry for a supplier and therefore hopefully reduce the price, right?
Yeah,
There's some work that is pretty standard now, which is let's reduce the risks of payment. Unitaid and Chai developed a reputation to pay on time, where not every individual program had that reputation, and for those that didn't, they'd get a much higher price from a supplier. There's a piece of the pie that, if I recall correctly, that was forward pricing. We're going to project volumes. We're going to tell you what volumes are, and we are going to put our reputation on the line, which is we're going to meet those volumes.
that's right.
Then there was this question about the stable supply and market entry. And these were two sides of a similar coin. We need to have multiple suppliers in the market because if one manufacturing plant has a problem, they can't supply and we need a backup supplier. So we want supply stability, but we also want competition. Because when there's multiple suppliers in the market, they're going to compete on price. There's not, a duopoly or a monopoly behavior. And so we're going to compete and we're going to continue to try and win, which means if price is the single most important factor, we're going to reduce price.
Yeah.
So these are all steps that were taken to help drive down the cost and therefore the price of this critical drug. But it all started with building and aggregating demand, working with each country to purchase the same product. And can you comment on how hard it is to harmonize or get doctors across multiple countries to get the same guidance? That's such hard work.
Well, yeah, I mean, my colleagues who are in, at the moment, over 36 different countries, working individually with each country's government and national program to figure out how to get the demand right. When is a program going to use a drug? How are they going to buy it? What's the standard they're going to require for it? When they do their hard work, it's easy on the supply side to make things work. And honestly, that's the secret sauce. You're going to have some agency with a group of experts who know all the different drugs out there. They've given a lot of time and thought to this, and they make recommendations on treatment. In the US, it's been the US CDC. If you look for HIV, the US CDC has treatment guidelines for HIV. For a lot of low and middle income countries, they write their own guidelines individually at the national level, but they tend to queue off of the World Health Organization, WHO, who has a phenomenal group of experts who write treatment guidelines for a variety of conditions, including HIV. And WHO, when they're making their guidelines, they're considering how well do the drugs work? What's the potential toxicity? For HIV, we have HIV drugs being prescribed basically by trained community workers, not even necessarily doctors, because they're so safe and there's such a clear and easy practice for diagnosing and treating patients. So the WHO is asking, like, do I have the confidence in this new drug that it will fit in the same health system and the same paradigm? So we had to do a lot of work with WHO to make sure. And whenever I say we, I'm not talking just about CHAI, right? I'm talking about the global health community of which we're a part. Unitaid is a huge part. Gates Foundation is a huge part. And we had to do the work to make sure WHO had all the information to include tenofovir in their guidelines. And then at the national level, we had to work with national experts across all the countries where we're present to do the same. Ultimately, this is a national government's decision. Like, how, for my population, am I going to measure risk versus reward? And it takes a lot of work.
So that whole idea of demand aggregation, really hard work. And I often hear really intelligent people saying things like, if only we had this product, the world would change. And my response often to that is, who's going to buy it? Who's going to use it? And is it the same product that you want across all of these disparate programs? And unless that work is done, boy, you don't even have a starting place to do any supply side work.
Yeah, I mean, put another way, Inder, there's a lot of incredible innovation and scientific ingenuity that goes into discovering and developing new products, right? But unless you're solving a specific problem and your product meets 10 out of 10 attributes that are required to solve that problem, you could develop the most ingenious thing out there in the world, and the market isn't necessarily going to throw you a parade. And so if you don't have some connection between this scientific discovery and the development of new products and detailed understanding of what the needs are of the market, what are the attributes the market needs, and match them up, you could cure cancer, but if you do it in a way that no one can afford, you still have a problem. So being part of an organization that works on both sides simultaneously and has a way for information to feed back in both directions. Hey, national programs, a new product's coming. It's going to look like this. Start talking to your patients about it. You've got to do all of that before day one when you put some bottles on the shelf to sell.
If you could wave a wand and work on one thing in the world today, what would you want to work on?
Oh, and it's like asking someone who your favorite child is. And I mean, I just don't have one. I can throw out there that there are some relatively neglected wins. One example I would give is hepatitis C. Hepatitis actually was on track to become the largest infectious cause of death globally this year, overtaking TB, overtaking HIV, overtaking malaria. But hepatitis C cures came out. You see them advertised in the US all the time. These cures are 95 to 98% effective. That's more effective than most antibiotics. Like, I could run a hepatitis C elimination program and the entire cure costs $60. So, unfortunately, we're in a world where all of these different health indications are competing with each other. We have a shrinking pool of resources globally, and there's just a limited set of attention. But anyway, hepatitis is one. Drug-resistant bacterial infections should terrify everyone, and there's a lot of data out there. Multiple drug-resistant TB. These are injections you're getting for 2 years, with side effects like deafness and psychotic break. They're now oral treatments that you take for 6 months at a fraction of the cost. without these horrific side effects. So what we talked about with tenofovir is a drop in the bucket in terms of what's needed out there.
Dave, it's been a real pleasure to have you on the podcast. You're clearly doing amazing work. Thanks so much for joining me. I'm really excited to see what you and the team do next.
Thanks, Inder. It's been a pleasure.
Thanks for listening to the Market Shapers podcast. I'm Inder Singh. If you enjoyed the show, please like it or leave us a review and subscribe in your favorite app so you don't miss the next episode. Market Shapers is produced by me with help from University FM. Special thanks to Renaissance Philanthropy, Griffin Catalyst, and the Digital Harbor Foundation for their support.